Hello, everyone. My name is Jennifer Chan. I'm a medical oncologist at Dana-Farber Cancer Institute in Boston. And I wanted to share with you today some information about an Alliance for Clinical Trials Oncology trial, the A021602 or CABINET trial. This is a randomized double-blinded phase 3 trial of cabozantinib versus placebo in patients with advanced neuroendocrine tumors whose disease has progressed on prior therapy. So during this very short presentation, I'll give you some background about the trial and some of the details of the trial as you may consider whether this is a trial that might be appropriate for you or someone you know. So as we think about systemic treatment options for patients with well-differentiated neuroendocrine tumors, I think it's helpful to think about the different classes of medications that are in use. For patients with GI neuroendocrine tumors, we often start with somatostatin analog therapy, whether it be octreotide or lanreotide. After progression, some of the agents that can be considered and that are approved include peptide receptor radionuclide therapy with lutetium-177 dotatate or everolimus. As we think about patients with advanced pancreatic neuroendocrine tumors, somatostatin analogs are often used in the first-line setting, but some of the options for treatment after somatostatin analogs may include peptide receptor radionuclide therapy or everolimus. In patients with pancreatic NET, we also will think about using sunitinib, which is a tyrosine kinase inhibitor, or chemotherapy with capecitabine and temozolomide. In patients with lung neuroendocrine tumors, somatostatin analogs may also have a role in the first-line setting, although not FDA approved. And for patients with progressive disease, we can think about treatment with everolimus or chemotherapy, oftentimes with capecitabine or temozolomide, sometimes with platinum-based therapy. So although there are many options that can be considered for treatment, one thing that's important to recognize is that we do need additional effective therapies for patients with pancreatic neuroendocrine tumors, as well as extrapancreatic neuroendocrine tumors, meaning the neuroendocrine tumors that start in the lung or the GI tract after progression on prior therapies. Because ultimately what we're hoping to do is expand treatment options for patients. As we think about potential new targets for therapy in neuroendocrine tumors, I'd like to show this figure because it gives you a good sense of the cancer cell biology. And this is a picture of a neuroendocrine tumor and some of the receptors that are important and located on the surface of the cancer cell. For instance, you can see the somatostatin receptor, and that's what's targeted with the somatostatin analogs. You can see the mTOR pathway, which is targeted by medicines like everolimus. But one of the other important targets is the VEGF receptor. And one thing we know is that neuroendocrine tumors are very rich in blood vessels. And angiogenesis, which is that formation of new blood vessels, is driven by the VEGF pathway. And some of the inhibitors of this pathway we know are active and effective in treating neuroendocrine tumors. Tyrosine kinase inhibitors, and I've outlined this in this red box, have been evaluated in neuroendocrine tumors, and they work, again, by blocking some of these tyrosine kinase receptors, which include the VEGF receptor. The only tyrosine kinase inhibitor that's approved in the US for treatment of neuroendocrine tumors is sunitinib. There have been a number of other tyrosine kinase inhibitors that have been evaluated in neuroendocrine tumors, although not improved, and they include, and I've listed on this slide some of them, axitinib, cabozantinib, lenvatinib, pazopanib, surufatinib. They've all been shown to have some activity in neuroendocrine tumors, but where they fit into the treatment pathway, particularly since they're not approved, and whether one is superior to another has not been well established. In the CABINET trial, we are evaluating cabozantinib, and this is a tyrosine kinase inhibitor that targets that important VEGF receptor, but it also targets other receptors that are important in cancer biology, including the MET receptor, AXL, and RET. This is a drug that is approved already in patients with advanced renal cell carcinoma, thyroid carcinoma, and hepatocellular carcinoma. There has been work that has been done evaluating cabozantinib in neuroendocrine tumors, and in some preclinical models, we have seen that cabozantinib can inhibit the viability, the growth of cancer cells that are neuroendocrine, and can also decrease spread, metastasis, and also invasion. Several years ago, we conducted a phase 2 trial of cabozantinib at my institution, Dana-Farber, and collaborators at Mass General Hospital. We saw with a phase 2 trial of cabozantinib in patients with pancreas neuroendocrine tumors, as well as carcinoid tumors, that there were encouraging tumor responses, shrinkage of cancer, and progression-free survival times. And this led us to develop the CABINET trial, which, as I mentioned to you earlier, is a phase 3 trial that is looking at cabozantinib versus placebo in patients with advanced neuroendocrine tumors. There will be 2 groups of patients in this trial. The first group is patients with pancreas neuroendocrine tumors, and the second group is patients with extrapancreatic neuroendocrine tumors, and we've named this cohort the carcinoid cohort. Patients, as you can see in this bottom yellow box, who are included in the trial include patients who have well or moderately differentiated neuroendocrine tumors. They can have both functional tumors, meaning there are hormone symptoms that they might be experiencing, or non-functional tumors. Importantly, all patients have to have had received prior therapy with at least one FDA-approved treatment. This doesn't include somatostatin analogs. And for patients with pancreas neuroendocrine tumors, prior therapy can have included everolimus, sunitinib, or lutetium-177 dotatate. For patients with lung neuroendocrine tumors, this can include everolimus. And for patients with GI neuroendocrine tumors, this can include everolimus or lutetium-177 dotatate. All patients have to have had at least one of these prior therapies according to their primary tumor site. All patients have to have had cancer that has grown in the past 1 year prior to enrolling on the trial. We do allow patients to receive somatostatin analog therapy along with the study therapy, provided that their dose of somatostatin analog therapy has been stable for at least 2 months. So again, for patients who are eligible, there is a randomization to either cabozantinib or placebo. It's a 2-to-1 randomization, which means that 2 out of 3 patients will be initially randomized to receive cabozantinib. 1 out of 3 patients will be randomized to receive placebo. Treatment is taken daily until there is development of progression of disease. At the time of progression of disease, there is an unblinding that is done, which allows us to understand what treatment patients were receiving. For patients who were receiving placebo, they are then able to cross over to receive cabozantinib. So everybody who enrolls on the trial will have the ability to receive cabozantinib. 1 out of 3 patients will start with placebo and then receive cabozantinib at the time of disease progression. The primary endpoint of the study is progression-free survival. So what we're really trying to look at is the amount of time until the cancer grows by what we call the RECIST criteria. And that's usually a 20% increase or development of new lesions. Some of the secondary endpoints that we're looking at is overall survival, response rate, which is the shrinkage of cancer, and importantly, we're also looking at safety and tolerability. Correlative studies that are included in this trial include measures of quality of life. We're also looking at blood and biomarkers to see whether there are predictors of benefit to therapy. And there are also some pharmacokinetic studies that are being done to look at drug levels in patients who are receiving treatment. So this is, in a snapshot, what the Alliance A021602 or CABINET trial is all about. And if you are interested in the trial, I would be more than happy to answer any questions about it. And it's also something that I would encourage you to talk to your own medical providers about to see if you might be a good candidate.